just to introduce myself for those who weren't here at the start of the meeting, my name is Kelly Semper. I work for Norfolk Waveney CCG, which is the clinical commissioning group. So as was alluded to at the very, very start, whilst I am very involved and very aware of the mental health services across Norfolk and Waveney for our children and young people, I commission them. So therefore I hold them to account and I assure them, but I'm not part of the delivery. I'm not a frontline worker. However, I do have experience in health psychology and kind of understand the clinical processes as well. So that's very helpful when it comes to trying to assure and improve our provision. So as I said, I'm fairly new. I still keep claiming that I'm fairly new. I'm not sure how long I can do that for, but I joined the system at the end of November, having come from, and hopefully this will be music to people's ears, having come from public health in Norfolk County Council, which is very much about looking at the data, looking at impact, and also making sure that we intervene at the earliest opportunity. So I understand a lot about intergenerational vulnerability and the impact of childhood trauma and childhood adversity and ongoing kind of repeated traumas, particularly things like young people not being seen and not being treated in the way that they feel they're respected in a system that should be helping them. So that's my background. I am part of a very small but perfectly formed team. So myself, I'm the mental health program manager for Children's, which means I have oversight of the general kind of ongoing day-to-day running of the various mental health programs that we have, both from a national priority perspective, but also a local priority perspective. And then we have a line manager called Bex Mann, who's come from the NHS regional team to head up our team. She's very much focused on the kind of crisis end of the spectrum. And then we have two new project managers that have started. One is focusing on the waiting list initiative, which I'll go on to describe a little bit more about as we go through. It's a big amount of investment that we've found kind of behind the sofa sort of thing to try and get some of our waiting lists for CYP mental health services down. And then Layla, who is joining us, is going to focus primarily on that education offer. So what happens in schools around mental health and wellbeing, which if you've turned on the news in the last 6 months, you'll realise is a significant national and also local priority. So let's try and click on. Has that worked for everybody?
Yeah.
Happy. Sometimes doesn't if it's just me seeing a screen. So for those of you that know about our vision for children and young people's mental health going forwards, this won't be a new slide to you. However, for those of you that don't, what we're moving towards across Norfolk and Waveney for children's mental health is something called the Thrive Conceptual Framework. And the Thrive Conceptual Framework was delivered by the Anna Freud Centre in partnership with Tavistock and Portman NHS Trust in London. And they identified that this approach to delivering mental health services for children was a best practice or a gold standard approach. Ultimately, what it means is that we're moving away in Norfolk and Waveney from a tiered system of support, which tends to historically exacerbate waiting times, because what it means is young people have to meet a threshold or they have to get discharged and re-referred into a different service if their needs change. That's going to stop. And what we need to make sure is that young people can move seamlessly between these needs-based groupings, which are on the right-hand side here. In Norfolk and Waveney, we're moving to a 0 to 25th birthday model, 0 to 25th birthday, which is quite challenging in and itself. Most services still across the national system, are 0 to 18 because of the challenges of integrating with the adult offer. However, we are aspiring to be a 0 to 25 model in Norfolk and Waveney. And what the Thrive Conceptual Framework highlights is that every young person is in the framework all the time. And we know this because we talk about this all the time, that mental health is, everybody has mental health. It's just people are on a different kind of journey on that continuum, depending on the day in question, really, the day that they come into contact with services. So 1 in 6, it's thought, are likely to need some kind of help, 1 in 6 young people, and that's gone up from 1 in 9. So there was a recent survey done by NHS Digital as a result of the pandemic, and they redid a survey that was done in 2017 with children, which highlighted around 1 in 9 would need some kind of more intensive support than kind of promotion of wellbeing and that thriving piece in the middle. Now it's down to 1 in 6, which is really scary, actually, and something that our systems are seeing with increased demand and also increased acuity, so increased severity of people coming through into our system. However, the majority of those young people will have their needs met by that kind of first level of support, which is called getting advice or getting advice and guidance. So these are young people and families that will be able to self-serve with a little bit of extra support, but won't necessarily need therapeutic treatment. So in terms of the conceptual framework and some core principles that we're trying to kind of adhere to in all that we do when we're delivering and developing our transformation programme, I've already mentioned one of the core principles is around a 0 to 25th birthday approach, which has its own challenges, as I'm sure you're aware. However, a few more of the key principles is that we want this system to be relationship focused. So we spoke a little bit about this in terms of reducing handoffs, but also promoting positive relationships between a child and someone that they trust, and ensuring that that relationship is able to give them the support that they need, and they can then call in more specialist interventional therapeutic support as and when required. We want clear access routes for everyone, ultimately, for children, young people and their families, but also professionals, so that there's one route in to service. At the moment, as was already described, there's a scattergun approach. We know that that happens where professionals particularly will refer to multiple different provision to try and get their young person seen as soon as possible. So we want there to be one access route and one offer for children, young people and their families. Again, already been mentioned, we've had some great conversations already this morning, but there really needs to be a focus on those that are thriving and a focus on that early intervention and prevention. And also those that aren't thriving, those that are having a bit of a challenge currently, I think that there's a real need to try and move them back to a state of thriving. And how we do that will be through many of these principles, including ensuring that we're really building on those trusted relationships with adults that they kind of hold close. Community-based is another really key part of our transformation model. We recognise that the local systems and the local services that sit around communities are actually crucial in delivering this model, and that includes the wider VCSE sector. And what we would really like, I mean, this is potentially quite a way into the future yet, but is co-located multi-skilled teams based within communities, so that they kind of come to young people and families rather than expecting young people and families to come to them. So that's an aspiration. Obviously, working as a single system goes without saying. So we would like, as a system, as a mental health system, to have a shared case management system. At the moment, all of our providers of mental health, it's probably not a surprise to you, have different electronic patient records, and that makes it very difficult to not only for a young person to move through different offers of support, but also for them to understand shared learning if a young person's kind of repeatedly come back and back into service. I've already mentioned this in terms of the community-based approach, but multi-agency and multidisciplinary teams are going to be crucial. And so we know these young people often sit in an environment whereby there are other things going on for them. So they might present with a mental health need, but there may well be other things going on, not only for them, but also their families. So we want to be able to draw on multi-agencies and multi-skilled individuals and have really proactive conversations about how we holistically support that young person and the family and network surrounding them. And then the last thing, which I think is really crucial, is that we want our service to be goal focused and episodic. And what that means in kind of layman's terms is that we want children, young people involved from the very beginning in terms of their journey around treatment, and we want them to set goals from the very outset. So we want them very much to manage expectations. And what we regularly say within the mental health system is that we, unfortunately, will not fix people. A lot of people come into the mental health system feeling like if they're not leaving completely happy with their life, that it's been a failure on the part of themselves as the participant, but also on our services. And actually, as I described in the previous slide, everyone's on a mental health journey. We all have mental health, and sometimes that will fluctuate. So what we want to be really clear on from the outset is this is the goal that this particular treatment intervention is trying to help you to meet. And when you meet that goal, fantastic. Go off, learn the tools, use the tools that you've learned over the last 6, 7, 8 weeks of treatment. And then if anything changes or if anything escalates, come back to us and we'll slot you back into our system, no problem. But we don't want to be there as a hand-holding exercise for years and years and years, which is kind of what's been happening, certainly with our youth service for many years. And it's meant that our staff are burnt out, frankly. So the outcomes framework that we're hoping to achieve, I'm not going to go through this in too much detail because I don't want to dwell on it too much, but it's not I don't think it would come as any surprise to you that we've got a huge amount of outcomes that if we're doing things right, if we're transforming our services right, we would hope to achieve. And they centre around three fairly obvious objectives, one of which is obviously supporting young people to have good mental health and wellbeing. So that includes things like young people are enabled and empowered to look after their own mental health and wellbeing, and they have access to these advice and guidance options that they can self-serve as and when is appropriate, but also that they get to the right place at the right time, and there's increased knowledge around their communities and families and how to support them. There's also obviously a secondary impact of that in terms of if you reduce mental health and wellbeing, you also reduce the negative effects that mental health and wellbeing difficulties have on a young person's functioning. So this includes much wider kind of socioeconomic determinants of health. So reducing the need for crisis, social care intervention, improve physical health. We know physical and mental health are inextricably linked. Reducing inequality gaps for things like developmental milestones, speech and language, etc. And also kind of a clear awareness of the system as to how to access support and where that's available, and actually making sure that everybody feels that they have a role to play. We've spoken about this already, but quite frequently in the system, everybody's really, really stressed, everybody's really busy. So it's kind of a natural first step to refer on to specialist support when actually probably all that child needs is a listening ear and some support on the ground. And so we're going to equip our staff to be able to support those young people if and when they don't need a referral to mental health services. And then lastly, improved transitions into and experiences of adulthood. This is a really key element of delivery. Obviously, we've moved to a 0 to 25 model, but actually what we want to be preparing our young people for at 16 really, and slightly older for those young people with an SEND, is to transition to adulthood and prepare for adult life. So we want to improve engagement with the universal services that those young people and also when they reach adulthood will engage with. So things like primary care, schools, colleges, special schools, universities, apprenticeships, and we want to engage in those areas. We also want young people to be able to access training and opportunities and improve their social mobility and give people the aspirations that they need to be happy, healthy individuals. And also that we really want young people's self-esteem to go up. We really want them to be confident, we want them to develop their independence, and we want them to have greater autonomy and understanding in terms of giving themselves their own role in their recovery and getting them to articulate when things aren't going so well for them. So again, another busy slide, apologies, it might, and like I said, I'll share these with everybody after the meeting, so you can have your own, you can take sort of your own time to read through this. But this is almost, we often refer to this as kind of a mobile phone chart when you go to a mobile phone store and you've got all the options. However, this is kind of a one-stop shop really, a one-pager of all of our various priorities as a transformation team, where we were when we did the Rethink Partners evaluation in 2019, where we are kind of now in the middle, and where we want to be over the next couple of years. So again, I won't dwell on the kind of specifics because it's very busy. However, there's certainly a kind of a real requirement to have senior systemic decision-making boards involving stakeholders and getting everybody involved in that kind of movement to a more integrated system. We want to obviously link to the advice offer, provide some kind of integrated front door for all referrals to CAMHS, but also to be able to provide a single point of access for advice and guidance for both professionals, families, and also children and young people themselves. And we also want physical front doors. So we mentioned those community bases. So we want to get to a place in the next couple of years whereby we have community-led initiatives whereby people, young people, families can drop in and get the support from a whole variety of different professionals depending on the needs that that family have. So we've also got an area called different ways of working. So at the moment, there's quite a sporadic and fragmented triage process. So all of our providers use different assessments and use different triage processes. We've now moved to a place where they all adopt the same assessment. So there's a shared language and the same triage process. And there's actually 5 meetings a week where all providers of mental health services come together and discuss cases, so that there's quite a significant amount of joint working, I suppose, to ensure that a young person that possibly needs to be stepped up or stepped down can do so seamlessly without having to be discharged and re-referred and then put to the bottom of that, those waiting lists that we all obviously know too well. And then lastly, data and information. So there's a huge amount of both qualitative and quantitative information that we need to gather to understand impact. And we've set up with MAP as our lead partners, our lead provider, a participation social recovery model, which some of you may be aware of. Jo Hand in MAP is leading on that, and she would be more than happy for any of you to get in touch if you want to be involved in any of the co-production and participation work that her team are leading. But also we wanted, from a very quantitative perspective, to have a shared data set. So again, similar to the triage and assessment forms, none of our providers were collecting the same information. So it makes it very difficult to understand actually the potential stresses, strains and pressures on different parts of the system. If we weren't all kind of comparing apples with apples, it was difficult. So now we have one single minimum data set that all of our providers collect and report on. So the blueprint that I said I try and manage is quite extensive, and this is kind of a snapshot of the various priorities which might be of help to you guys in terms of who to link in with and how to link in with them going forwards. So nationally, as I said, Beck's our line manager in our team, comes from region, and there are a number of 6 to be exact national focuses that are mentioned in the NHS long-term plan, and they're listed down the left-hand side here. So improving access to services sits at 35%, but that is a minimum access target of 35%, and that is based upon national prevalence estimates. It's quite complex, but national prevalence estimates suggest that 35% of those we think need help should be accessing services. And I can happily report that in Norfolk and Waveney, our access has now gone up to 36%. So we have finally tipped over 35. For years and years and years, we sat at around 31, 32, and we're quite a black dot on the NHS England landscape. We're now at 36% and rising. So that's really, really good news. Outcomes is an interesting one. So what we would like any young person in our system to have is a paired outcomes score. So when they enter service and when they enter treatment, we want them to have a baseline score in terms of their goals and expectations of the service, and then have regular rechecks of that, the progress towards that goal, at least one at the start and one at the end when they exit treatment. So what we then have to do is flow that to the MHSDS, which is the National Mental Health Data Set. And in Norfolk and Waveney, we are very poor at flowing outcomes, very, very poor. So that's another national target that we need to start getting better at, that all of our providers of CYP mental health services should be collecting outcomes in the first case and also reporting them to the national team so they know that the children that enter our service are actually leaving meeting their outcomes. Eating disorders I will touch on later, so I'm not going to dwell on it now, but a significant national priority with a significant amount of pressure on our current system, particularly as a result of COVID. So we've seen 4 times the referrals regarding eating disorders into our system. Similarly with crisis, so particularly protected resource in terms of the new money coming down from national, but there's a massive amount of work going on in Norfolk and Waveney and nationally around ensuring that there's 100% coverage of a crisis response for children and young people, including alternatives to admission, so trying to support young people in the home to reduce hospital or tier 4 inpatient unit beds admissions, and having those right skills and right team members in the community supporting children where they need it most, really. MHSTs, mental health support teams, are the 5th national priority, and they support that access, that 35% access target, and these will be the teams that you'll have heard of on the news that are being rolled out in schools. So this is a nationally funded initiative. It should be additional and new capacity into the system. However, it is a very drip feed situation. So MHSTs currently across Norfolk and Waveney, we have 2, and each team comprises of 8 members of staff. So we've got 16 members of staff in the system in MHSTs at the moment. They are based in the north of the county and the west of the county. And we've got 2 more teams in their training year, which are based in Lowestoft for that Waveney bit of the system that I was talking about at the start, and also Thetford for that South Norfolk bit. And we've been given a further 6 teams over the next 3 years. So in total, by 2024, we should have 10 teams, so 80 additional members of staff supporting children and young people prior to a referral to CAMHS within the school community. And so that's really exciting. And that applies to all schools. So that could be primary, secondary, special, alternative provision, or otherwise colleges as well, colleges and universities class in that as well. And then lastly, as I said, the 0 to 25 ambition is one that's nationally directed. So there is a kind of comprehensive offer being designed across our system for 0 to 25-year-olds. But there is a particular focus, as I say, on that 18 to 25-year cohort, because that is the complex end of the spectrum, particularly when we look at the various difficulties in getting into community mental health teams in adults and the thresholds that young people have to meet that community mental health standard in adults, but also 0 to 4. So the parent-infant offer for children, young people around mental health and attachment is lacking in Norfolk and nationally, so we really want to focus on that. So in terms of our local transformation, and some of this I'll go into a little bit more detail because I think you'll be interested to hear about the waiting list reduction and our single point of contact. But we have had a significant, almost £750,000 invested into our waiting lists across our system over the last 3 months. And we're now starting to really see an impact of those waiting list monies going, supporting not only Point One, which is our kind of early intervention provider, but also into NSFT's more complex waiting lists and teams. The single point of contact I've already mentioned, so getting a clear access route to service. We've just had a project manager start who's going to drive that piece of work forwards and try and really links to the next point, but around using digital innovation to ensure that the referrals that we get into services are really robust and of a good quality, so we can make informed decision making that very earliest referral. Data sharing and electronic patient record, again, I've mentioned, we want to get everyone that's providing mental health services onto the same electronic patient record for the reasons I mentioned before. And we're about, I would say, in terms of a roadmap, we're probably about halfway there. We've got really good engagement with NSFT and other providers such as CCS who sit on System 1, and we're now working through the kind of infrastructure conversations as to how people get access to those various systems and how they interface with one another. And then demand capacity and optimization is a piece of work that I'm leading on. In terms of understanding, it's probably be a surprise to you, but we don't really understand our true capacity in the system because we have had, as has national teams, a real difficulty in recruiting and retaining staff in our children and young people's mental health service. So we're doing a really, really comprehensive piece of work trying to understand the current capacity and where our skills are. And where we need to recruit additional skills to meet the needs of children and young people so that they can get seen sooner without waits. That links to the appropriately trained workforce, which again, national priority, don't need to explain that really. It's just ensuring that we have enough people with the right skills in our system to meet the needs of children. Finances, I've got a slide on this later. However, the financial envelope is complex for NHS commissioning generally. NHS commissioning would like us to have block contracts with every provider that provides a service, which means it's quite hard to disaggregate the various service lines in those block contracts. If they're worth 100 million, for example, how do we know that a certain proportion of that is absolutely being spent on children? It makes it very difficult. So I'll talk a little bit about that at a later slide. Performance and contract management speaks for itself. All of our contracts that we set up in April with our new providers have got a service development improvement plan, so an SDIP, and also a data quality improvement plan aligned to them, which ensures that we can hold our providers to account and make sure that we're improving services as a system together, not on our own. And then lastly, it's in red because I think it's very, very crucial for this conversation and others I've been recently having, but we're very much aligned to the work that Claire Angel is doing around transforming the NDD offer. That's not to say that our system or our providers aren't in need of significant improvement around this offer. However, Claire is very much working with our community paediatric teams and the NDS service to make sure that children and young people are seen as quickly as they possibly can, but whilst they wait, as I said, there is an offer for them so that they're not just almost left to deal with their needs on their own. So that's very much about us working in a collaborative way. And then lastly, we've got quite a number of transformation work streams which are penned as kind of integrated care system or ICS development. So these are all the pieces of work that we're doing with other people. The first two were very much mental health focused. This is very much system and partnership focused. So as you can see, system working is the first, making sure that we've got social care records and mental health records being able to talk to one another, integrated ways of working with education and health and social care to make sure that we're improving patient safety. And again, that single care, shared case management and assessment across providers also applies to a shared language with social care, so that social care teams feel equipped to be able to meet the needs of low-level mental health presentations, so that it's not always the default reaction for every young person to be ultimately on the end of a waiting list and committed to treatment, which isn't always the best course of action for them. Co-production engagement, I've already mentioned, Johanne's leading that, but we want to ensure that the voice of the children, young people and their families are really embedded in the centre of everything that we do. Early intervention and prevention is a huge programme of work. It seems remiss of us to just put it as kind of one dot on the landscape, but there's a huge amount of work going on at the moment in terms of how we work as a system with mental health as a significant priority to intervene earlier. And that's very much aligned to the wider Norfolk and Waveney vision in ensuring that families are able to flourish. So we're working with Norfolk County Council and Suffolk County Council colleagues who also are driving that kind of early intervention and wellbeing and education agenda. Primary care, absolutely a key provider on the landscape ultimately, and there's a national directive around having one mental health practitioner this year in every primary care network, increasing year on year. That was originally going to be an 18 and over offer. However, Bex and I banged a drum continuously for about 3 months to get that practitioner skilled up to be able to meet the needs of young people as well. So we have now got the go ahead for those practitioners to be able to meet the needs of children, young people from 14 and upwards in practice, which is really, really great news. And then 2 areas around equalities. Something about working with criminal justice, which is yet to be kind of determined, but that's very much linked to Section 136 suites. And also we have mental health practitioners within the police control room. At the moment, we fund that as a CCG, so kind of looking at the impact of that and seeing whether we need to continue to invest or invest more in that offer of support. And then all of the stuff around the edge of care and in care and adopted children, very much a key priority for children's services, but something that we're very much focused on because they're embedding mental health support within those specialist teams. So last kind of 4 or 5 slides for you in terms of what we're doing, which is probably the key things that you want to know. So as I mentioned at the start, we've got a continued high demand on our services. The general national view is that we should be expecting around a 20% increase in referrals as a result of the pandemic. So that's something absolutely that we need to bear in mind when we're thinking about our demand and capacity work. Integrated commissioning is always a challenge, not only with social care and adults and education, but also because we focus on Norfolk and Waveney. So those teams across the Norfolk County Council are fairly easy to engage with. I've got really good links with them because I came from Norfolk County Council, but the Suffolk County Council teams are harder to get around the table. So we need to continue to do that. 18 to 25 offer, I've already mentioned, really difficult in terms of how we provide a really clever and robust service to meet the needs of those 18 to 25-year-olds who probably don't necessarily sit within the principles I identified in terms of that goal-based and episodic intervention. So many of our 18 to 25 young people in our complex support system will never be discharged from service, but for whatever reason, they don't meet the thresholds for adult social care either. So it's how do we work with adult systems, how do we work with adult social care to meet the needs of those young people? Eating disorders, I've mentioned, however, we are, worth mentioning again, is we are developing an ARFID pathway. And for those of you that don't know what ARFID is, it's avoidant restrictive food intake disorder. It's now recognised as an eating disorder in its own right. And it's very much linked to sensory need rather than body dysmorphia, which the traditional kind of eating disorders that we're all aware of sort of centres around. So it's very much young people. There's quite a high presentation of men with ARFID actually, or boys with ARFID, and they tend to have, not always, but they tend to have SEND or NDD related needs because it tends to be about mouthfeel or a fear of being sick and that type of thing when they're avoiding food intake. However, we need to create our own pathway for that. So that's one of our priorities. NDD, including ASD and ADHD, significant weights. I don't need to tell you guys that for diagnosis, but also there's a lack of adequate support and provision with no clear treatment pathway whilst they're on those waiting lists. And that's where we can kind of come in and help and ensure that our mental health teams are equipped to meet the needs of any young person presenting, regardless of whether they're waiting or have had a diagnosis of NDD whilst they wait. Crisis. A significant pressure that Bex is kind of primarily focusing on in terms of her role. However, we do have a limited number of tier 4 inpatient beds. So we have significant young people horrifically sat in our acute services, in our acute hospitals, getting the treatment they need there, but it's not the best place for them, as I'm sure you're all aware. And so we're working out how we can support those people, support those young people and their families to kind of move into community and support them kind of on the ground rather than having them in a hospital bed. Shared APR, electronic patient record, we've spoken about that. And then lastly, before I talk about waiting lists, cultural shift. And this can apply to all of those various things we've already mentioned. Our mental health system is under pressure, as are all NHS systems, particularly in light of COVID. However, there is a real challenge in our system in terms of changing cultures. And that's something that we have to do from the bottom up. So we're doing a lot of engagement work with our providers and our frontline practitioners to try and understand the reasons for why they do what they do, why they find it really hard to discharge, what the barriers are to discharging young people, what the barriers are to accepting young people into service, particularly if they've got a complex or additional need, and why we need to be moving from kind of more of a clinical diagnostic model into a needs-based model. And that's quite uncomfortable for some of our practitioners who've been in the system for years and years and years and are very diagnostic focused. We want that to be kind of secondary to actually what are the CYP needs in the system, and how do we meet those needs rather than the diagnosis that's presenting to us. And then bottom left of the corner, long waiting lists, getting people into service as and when they need them, and in trying to get rid of those waits. And that is, it's not an elephant in the room because we brought it up a significant amount of times when we talk at these types of presentations and types of events. However, those waiting lists are a significant time zap, as you can imagine, on practitioner and clinician time. So just to give you an example, in NSFT, particularly the central youth team, there is around 20 hours a week per practitioner. And if you imagine they're only working a 36-hour week, 20 hours a week where they manage that waiting list in that system. So they're ringing people that are RAG rated red to make sure that they're okay and they've not gone into crisis. They're ringing the people that are rated amber every 2 weeks to make sure that they're okay and they've not gone into crisis. Those that are green get a call every month. And if you imagine those waits are in the hundreds for one of the teams, for the central youth team, that's a significant amount of time that those practitioners that want to be treating people are having to do to sustain those waiting lists and make sure that everyone's safe. So I mentioned that I'd talk about funding. It's always a difficult conversation. When you hear nationally that they're investing more and more in children's mental health services, it's not untrue. It's being resourced very well. However, that comes in kind of a history of significant under-resourcing of children's mental health services. So in terms of the budgeting, nationally, if we provide a 0 to 18 model, we should get 20% of the overall budget for mental health in each area. And for a 0 to 25 model, which is what we have in Norfolk and Waveney, that should sit at 28%. And currently, first glance, we're trying to disaggregate those block contracts, which I spoke about being very, very difficult kind of at the moment. We think we're at about 10%. So 10% of the funding that goes towards mental health services goes to CYP service lines. And like I said, it should be 28%. How you get around that is very difficult, because what you hear from providers is, well, we're spent, we're actually overspent. So how do you expect us to take money from somewhere else and put it into children's? So there has to be a long-term plan as to how we're going to start diverting some of that resource, or working in a different way to divert some of that resource to children's service lines. However, there has been some real success stories with new monies. We've got some great projects being led by our VCSE sector organisations aligned to winter funding. We've got supporting the expansion of the CASE, or the crisis offer, for children and young people, and to reduce those admissions to hospital, which we see going up and up and up as a result of the pandemic. We've got 1.5 million over the next 3 years to improve, that's on top of baseline, to improve eating disorder offers across Norfolk and Waveney. And as I said, we are working very, very hard at disaggregating that adult block contract with NSFT to ensure that there's equitable funding to deliver against those service lines that we know is a priority. So this is just another articulation really of a CYP journey. So we work quite hard with children, young people and families in MAP, which is doing that kind of participation and recovery model, to understand kind of the ways in which they hope that they would approach our services. And this kind of just articulates what they've said, that they want a kind of be needs led, they want it to have one access point, they want to be able to get advice at that access point, but also be able to get triaged and assessed, and then have a menu of interventions which they share in the decision making in terms of which intervention is offered to them. So last few slides, just to give you some sort of nitty gritty information. As I said, the key challenges are around access and waiting lists at the moment. And so we know that the 0.1 single point of contact has around 850 children on the waiting list. This is slightly delayed because we have quarterly reporting. So it is about 850 now. It's gone down by about 200. But they are waiting in excess currently of a year to be screened, and there's no acknowledgement of that referral. However, what's happening, or what has happened now, and some of you may have received this if you've been waiting for a 0.1 intervention, is we've been sending letters out to all of our young people and families on the waiting list. And that gives them a leaflet and also some helpful hints and tips to be able to kind of support their own mental health and wellbeing while they wait. And as I said, £750,000 has been invested into the waiting list, around 390 of that on 0.1, to add additional resource. So we've top sliced all 850 children, and we have basically said these sort of 6 members of staff are now going to work through those waits, and we're going to see them as soon as we possibly can. We're going to triage, we're going to assess, and we're going to put them in treatment as soon as we can. And then the current treatment and SPOC team, the non-additional resource, are kind of working almost from day dot on improving the processes to make sure that any new referrals into system get seen at the earliest opportunity. The other thing that we're obviously focusing on is NSFT weights. So they've also been given a significant amount of money, close to around £250,000, £300,000 for one specific team, Central Youth, to be able to employ some agency staff members to actually get some of those young people into treatment sooner that are on those kind of red and amber RAG ratings, so that we can kind of get them seen and off our waiting lists and getting their needs met as quickly as possible. So as I said, waiting list initiative, these are the key points. I won't go through them, but the things that we've kind of still yet to do is ensure that there is a shared triage form between CCS, who are our community provider, Cambridgeshire Community Services, and also 0.1, to make sure that young people that just need advice and guidance can be directed to CCS, which will be able to meet their needs that day, which is fantastic. We're also trying to improve patient flow and improve pathways. And we've spoken a lot about how we want to try and get young people into the services at the first opportunity, one front door, integrated front door, one place for referrals. But actually, if you're not then getting them out of the back door at the end of their treatment and having met their goals, you're always going to have like bottlenecks within the system. So we're doing a lot of work in terms of how we improve that flow through the system, and how we have really robust supervision and discharge planning practices within our providers to make sure that that can be done safely and efficiently. So this is the leaflet that goes alongside the letter, which some of you will have seen, some of you won't have seen, and I'm more than happy to get copies of this sent to anyone who's interested. We've got them sat in kind of GP practices and also around our provider kind of hubs across the county. So if you do want to have access to this sort of self-help and support guide, please let me know and I'll send some copies out. But ultimately, it really centres on things that you can do to access support in the here and now while you wait. So not just is it going to focus on kind of numbers you can call and internet and apps you can download and things on the internet, because we know some young people and some families don't have access to those resources. There's also a really comprehensive section at the back which does some kind of self-help techniques and hints and tips, so they don't have to have access to the internet if they don't have access. Lastly, I mentioned I'd talk about eating disorders. The numbers speak for themselves. If you look at the bottom right, the bottom graph on the right hand side, that is the reality of the situation as a result of COVID. Eating disorder referrals, both for routine, which to those young people that are referred and needing to be seen within 4 weeks, and complex and urgent, which are those referrals that need to be seen within 1 week, have shot up. And as you can see, top left graph, they are the urgents. So about quadrupled in terms of urgent referrals into the system. However, like I said, we do have a significant amount of investment being plugged into eating disorder teams across the country. And so we are hoping to see a real dramatic impact on that when we start to get new staff into place. This is the single point of access. I've already spoken about this, but the vision and plan. So we wanted to be a one-stop shop to be able to provide professionals, parents, and also children and young people with advice and guidance and triage. And then obviously, if deemed appropriate, to a full assessment and allocation to appropriate treatment pathway. We want it to be not only, there's going to be a digital kind of offer in terms of the referral mechanism, so you'll still be able to make a referral. However, we want it to be a very phone-based offer that John kind of currently provides. So very much all the information about a young person is collected, and those conversations happen between parent, child, and a sort of a very skilled practitioner at that front door to collect all the information that they need at that very first opportunity. We want to tip the current SPOC on its head. So at the moment, we've got fantastic, but not particularly senior practitioners at our front door. And actually, if we've learned anything from national models and also our CADS model, you want your most senior practitioners at the front door, offering that kind of advice and guidance, and also be able to make sort of robust, safe decisions. So we're going to put it on its head. And we also want to be needs-led, not diagnosis-led, which is kind of one of our taglines almost, so that young people are really, really very much a driver on their journey through their treatment.